Okay, gang. Like I said, I have Dustin here. I just want to just welcome Dustin. He's a senior critical care fellow who also happens to be neurologist slash engineer or PhD. You got your PhD in neurosciences, right? In engineering degree, of course, because he didn't have enough. And he also did his extra training, fellowship training in transcranial Doppler and neurosonography. So he's well posed to be the local expert here. So I just want to welcome Dustin.
Thanks everyone for showing up. As Brian said, I'm going to give a segue, sort of a brief introductory lecture on transcranial Doppler as it pertains to the critically injured, i.e. in the confines of the ICU. It's meant to be an interactive discussion. I know that Zoom can sometimes be challenging to make that happen, but please feel free to interrupt me as I move along if you have questions. And I hope, we hope we have some good discussion around transcranial Doppler. So the objectives of the talk are pretty straightforward, and it's to do any kind of imaging. I think you have to have a good understanding of the anatomy of the underlying parenchyma that you're imaging. So we're going to learn the anatomy fundamental to the use of transcranial Doppler. I'm going to give you a basic sense of TCD technique as we use it as intensivists and intensive care fellows. And then to be able to identify some of that pertinent anatomy in real time under ultrasound guidance. And then have at least a basic understanding of the principles of Doppler interrogation and TCD waveform analysis. And then I'll go through some examples of cases and uses of transcranial Doppler in both a medical surgical, a CVICU, neuro ICU, so broad uses. So to start, let's start with anatomy. And probably the most important anatomical structure for beginning transcranial Dopplers is this confluence of bones on the lateral sides of the head, and that's called the pterion, where the parietal, frontal, and temporal bones all come. And that's an important structure because that is the thinnest part of the skull and makes for insonation of underlying parenchyma, vessel, etc. Okay, so lateral temporal bone, pterion. That's the first structure you must know to be able to do TCD. The next one is the parenchyma and the cerebrospinal fluid. So you don't have to have a detailed knowledge of neuroanatomy, but you must be able to identify at least two key structures, and that is the midbrain, which we will talk a little bit about as we move along. And that is also the CSF space. That is important because those are the anatomical structures that you look for as you start to interrogate the vessels, which you are going to insonate. And then, of course, the vessels themselves, this famous anatomical structure, the circle of Willis, which is a confluence of the great cerebral arteries of the head. And most importantly, for the transcranial Doppler, for the non-neurosonologist, is really you want to interrogate MCA territory waveforms, because for the most part in the ICU, we are looking for global phenomena like vasospasm, ICP, etc. Okay, so how does the technique actually work? The caveat here is that most of our patients in the ICU don't quite look like that, i.e. they're not sitting up in a chair without the placement of an endotracheal tube in their gullet. So regardless, what you want to do is you want to get the head of bed at around 30 degrees. And, just like all the other procedures you do, make sure you're not leaning over and developing lumbosacral polyradiculopathy that will affect your career later on. And then you use the phased array transducers, the 1 to 5 megahertz probe. And most of the machines, and indeed the machines that we have, at least at the University of Alberta Hospital and at the Royal Alexandra Hospital, the sonocyte machines, have a TCD preset. There's 2 ultrasound machines upstairs in neuro ICU that do not have the TCD preset, but you see here, it's kind of funny. My apologies. So you can just use the cardiac preset in that case, and that'll be just fine. And so the first structures that you feel for is you just look for this scooped out, the scalp part of the temporal bone at the level of the eye with the dot on the probe pointing ventral, okay? And once you get there, that's roughly the spot that you want to be in. And then you just slide and sweep until you find the relevant anatomy, which we previously discussed, but might look a little bit different than it does on an MRI or a CPA, okay? So the relevant anatomy is really just two structures. And so what I'm always looking for is, first, find the contralateral temporal bone. So it's this hyperlucent structure that pretty reliably sits about 16 centimeters away from the probe on the skull. And so then that's, you have ipsilateral and contralateral skull. And then what you want to start looking for is this Mickey Mouse structure. Again, it's that midbrain structure, and it looks just like that on ultrasound as well. So you have the midbrain, you have the contralateral skull. You know that the midbrain is where the PCA territory arteries course. So just ventral to that must be your MCA territories, and that is where the circle of Willis lies. Okay, and that's just demonstrated here with. Yeah, it looks like Mickey Mouse. It looks more like a demonic Mickey Mouse, not the happy Mickey Mouse. But, and then the other structure that is really important to identify because it is directly midline in the cerebrum is the third ventricle. And in my mind, every time I see the third ventricle, I think of a cheeseburger because it has, it looks like two buns with a little hamburger in between it. And I won't even tell the story, forget about it. But so it looks like a cheeseburger, and that's important because that is directly midline, and again, that's exactly where your circle of Willis is going to sit. So you're in the sweet spot before you even turn on your color Doppler to say, okay, I know I'm going to find some kind of vessel here that I can insonate and interrogate. Okay, so. Then what you have to do is you turn your color on, okay? So you turn your color on, but before, you're going to get lots of color and signal and everywhere, and you're going to get all kinds of aliasing. But the thing that I think about first before I think about color is I think about at what depth am I going, and what depth am I seeing the color? Because the MCA is very reliably between 4 to 6 centimeters ipsilateral depth, okay? So very reliable. And then, and it really should be pointing straight up at your probe. If you think about the brain in this configuration, MCA arteries sit out like this, looking straight up at you, okay? And so 4 to 6 centimeters, you see a color signal, looking straight at you, and then the flow is going to be towards you. So it's going to be represented in red. If no one's done any ultrasound here, obviously red is towards and blue is away, right? So once you've identified, you feel confident that you're sitting right in the middle of the MCA, and sometimes you want to actually interrogate the entire vessel. You want to interrogate proximal MCA, distal MCA, particularly if you're doing acute stroke or thrombolytics in the context of acute stroke, though it's not used very prominently in this institute. In some places in the United States, they use this quite a bit. So after you've found the vessel, you want to turn on pulsed wave Doppler. And again, you want to ensure that you don't have this big angle of insonation, and really you don't want to have it greater than 10 to 15 degrees. And that's really all in the Doppler speed, right? Which is affected by the cosine of the angle of insonation. So if you're at a cosine angle of 0, you're close to 1, and that's ideal. And if you're at a cosine of 90, that becomes 0. And so you actually get no flow when you're at that angle of insonation. And then what you'll see when you do this is you get this lovely NCA spectral Doppler waveform that's created in the bottom here. And you can see that one of our new intensives here, Vince Lau, is also interested in this. And this is a really wonderful paper that he's done looking at ICU-TD that I leaned on heavily in the context of this talk. But the take-home message that I want to give to you guys right now is that, it's all great and it's wonderful. Like, oh my God, like I can interrogate the vessels of the cranium and the cerebrum. But the truth of the matter is that this does have limitations. And TCD, 15 to 20% of patients that you try this on will just not have obtainable TCD windows. And that becomes a real problem when you're trying to interrogate cerebral circulatory arrest for example, where you say, oh, I don't see any flow, I don't see any vessels. But if you have not demonstrated previously that there was flow in those vessels, you really can't see anything with respect to stream circulatory events. Does that make sense? Are there any questions? I feel like that's almost a question. Okay, so I want to go through a couple of asides before we start digging into actual ICU cases. And the aside first is, and I kind of harped on it a little bit, but I find that it's so important to know the depth and flow patterns before you start sticking these things on heads, because you can start interrogating all kinds of different vessels that in fact might not even be arterial flow. So the most important thing, yes, you can instigate all of these vessels via different strategies, and I'll briefly talk about. The most important thing to know is that the MCA, ipsilateral MCA territory artery, it universally, reliably lies between 4.5 and 6.5 centimeters below the ipsilateral temporal lobe. Okay, the flow, again, in a normal MCA territory, will always be towards your throat in normal physiology. Okay, obviously it can be abnormal in disease states where intracranial pressure is raised.
Dustin, just a question.
Yeah.
Do you actually reduce the depth of your or when you said that you were showing the contralateral temporal lobe, but you may do that initially, but then you reduce your depth just to get a better definition of what's going on.
Exactly. Yeah. So much of the same way when you're looking at, cardiac ultrasound, you're doing peristernal long axes, and you look broadly to see, do I have a pericardial effusion, what's going on? And then you zero in. And I zero into, sort of like a depth of about 8 centimeters. So I'm trying to cut it right in half so that I can really interrogate that sort of 2 centimeter vessel. Yeah. So the next aside is that, and what is critical to understand is once you understand actually how to get this vessel, reliably identify this vessel every time, reliably put pulse rate Doppler out, reliably get the waveform, is you have to understand what a normal NCA waveform looks like. So, when I first started doing this, I just did transcranial Doppler on every single person that came into the ICU, so I could get an armamentarium in my head of what is a normal MCA waveform look like, and what is a normal variation in the MCA waveform, before I started talking about what a pathological waveforms look like. And for the most part, transcranial Doppler, at least as you see it, like officially, if you were to order transcranial Dopplers in this hospital, and we only have actually one neurosonologist that does this, Carol, they use a different kind of machine, and they use what's called a power motion Doppler, which is basically a multi-gated M mode. They can insonate that entire vessel at once. It can actually insonate a big chunk of the circle of Willis, and that's demonstrated, right here in the upper part of this left-hand panel, where you see flows towards you and flows away from you. So and then you can look at all those in real time. So you can look at terminal ICA, which should be at about 6.5 centimeters, and you can mark up the MCA territory. So it's very powerful and obviously a little bit more superior than our point of care, because you can do all these things in real time, dynamically look at the MCA territory in real time, or the basilar artery territory, or the vertebral vascular, or the PCA artery, or the AC, on and on and on. So I just wanted to kind of demonstrate that, because I'm going to show you some of these waveforms as we go through, because I think they demonstrate some of the pathophysiology very well. But the real take-home point from this slide is that this is what the normal MCA waveform looks like. And it has this rapid systolic acceleration, and then this stepwise deceleration during diastole. Okay? And then you can see where the aortic valve closes in the dichrotic valve as well. It obviously separates systole from diastole. So it's alterations, perturbations in that waveform that ultimately determine physiology and pathophysiology, aberration from normalcy. Okay, so just one more side about the power of power motion mode Doppler. So, you know, if you really want something formal, you want to say, does this person have cerebral vasospasm? Does this person have shunt? This is the mode that you'd ideally want to use, okay? And often these machines, you can do stereotactic rigs with them as well. So if you want to do long-term involved monitoring, like, you know, if you had someone with infective endocarditis, for example, and you want to hook them up to say, like, are they having microembolic phenomenon going on? You can hook them up for 24 hours and go ahead and monitor it thereafter. So again, there's sort of two pictures here where there's power motion mode on the right, and then on the left is what more typically we would see as the circle of Willis on our point of care transcranial Doppler ultrasound. Okay, so both really great, but the power motion mode Doppler is superior in terms of really getting down to the fine details. So, and then as I alluded to before, you know, the MCA is for the most part where the money is at, but there are definitely other areas that you can insulate and are certainly important for different types of physiology. So for example, if you had someone that presented with a locked-in syndrome, you might be really curious about, is there a big thrombus sitting in the vertebrobasilar system? And you can interrogate that by a suboccipital approach that, you know, you insulate through the frame of mind and look at the basilar artery, for example. Same thing if you're interested about intracranial carotid artery, you can do a submandibular approach. And then if you're interested in a lot of stenotic vessels, you can do it through the eye to look at the ophthalmic artery. In our ICU, we do a lot of optic nerve insunnation for different reasons, and that's more optic nerve sheath diameter to look at, again, as a correlate of ICP that we often use in corollary with TCD to say, this person has ICP, we should improve. But you can do some really interesting things with insunnation through the ophthalmic artery. Okay. And then, so parameters that are critical for our understanding, again, to say, do I know what a normal NCA waveform looks like? A bit of a busy slide, so I apologize. And it kind of gives all the normal parameters that are age dependent in terms of your mean flow velocity, which is what we really care about, and we'll sort of go through the different velocities. But really what, you know, a mean flow velocity for an MCA territory waveform should be somewhere between 45 to 65 centimeters per second. And I just sort of remember that the depth of the MCA vessel is 4.5 to 6.5 centimeters, and the normal velocity is 45 to 65 centimeters per second. And that makes it really easy for myself. Okay. And then more important parameters. So, we'll, you know, we use these parameters and beyond the cerebrum, but pulsatility index or resistivity index, pulsatility index, you know, they're roughly the same thing, but they just have used pulsatility index more in transcranial Doppler than resistivity index. And so it's a very important parameter. And again, it looks at the difference between the peak systolic velocity and the end diastolic velocity as a function of the mean flow velocity, okay? And what that pulsatility index is really telling you about is distal things, okay? And distal things are ICP problems. So when you see a pulsatility index that's very high, in your mind, you should think, that's a distal problem, that's an ICP problem. Whereas if you see high velocities, mean flow velocities, that's a proximal problem, okay? And that you should think of vasospasm. It's a little bit oversimplified, but that, you know, MFV, proximal, vasospasm. Elevated PI, distal, ICP problem. So I separate those two things in my head. Okay, any questions before I go into some very specific examples of how we'll use this in the ICU? Anyone in the room? Everything makes sense so far? Okay, so the specific examples that I think are important, and I was going to do one on ischemic stroke as well, but I might save that for a later date just because it's a little bit more detailed and it requires a little bit more knowledge about velocity curves and stenosis and some physical principles that might make people fall asleep, especially in a warm room. So I'll avoid that for now, and we'll just go through the buttery important things, okay? And I'll highlight this by way of cases that we certainly see, maybe not so much in the general system much, but in neuro ICU, certainly we'll see some of these cases, okay? So the ones I want to see, detecting midline shift, elevated intracranial pressure, cerebral circulatory arrest. Notice I make that distinction between cerebral circulatory arrest and brain death. They are not the same thing whatsoever. Shunt, which we do a lot of, particularly in the context of Vincent and Brian's COVID-19 shunt study, and vasospasm, which we do not do a lot of, but I think it's important to understand how to do it, and it guides a lot of our principles. So case example one, I'm sure we see at least one or two of these a day. 69-year-old male admitted to ICU with intracranial hemorrhage. Etiology, as it always is, hypertension. And you note on the CT that there is some midline shift, and you are curious if that midline shift has progressed, okay? So again, this comes back to, can I identify the structures that are important that identify the midline, right? The demonic Mickey Mouse and the cheeseburger. So because the cheeseburger sets the middle of the cerebrum, right? And the contralateral temporal bone sets the outer limit of it. So from ipsilateral to contralateral temporal bone, let's just say it's 16 centimeters, and your cheeseburger is at 8 centimeters, you know that the difference between cheeseburger and contralateral temporal bone and cheeseburger ipsilateral temporal bone is moot, i.e. there is no midline shift. Whereas if your cheeseburger moved 3 or 4 centimeters towards the contralateral temporal bone, i.e. there's a difference between the two measurements, you know you have some midline shift, which is very quantifiable and correlates very well with you measuring midline shift on the CT head. Okay. So yeah, so that's method one of doing it, and then there's, you know, you can do it in the same method where you do ipsilateral insonation, contralateral insonation, measure from skull to midbrain, skull to midbrain, and see if the difference is there. Either way you cut it up, more than one way is to skin a cat, and you'll get to the same result. Okay, so that's how you measure midline shift. It's incredibly easy to do. You know, you could argue that it's maybe not that incredibly important because you can readily get CT heads, but I think it's a good skill to learn. You're learning how to do these transcranial Dopplers. This one we've seen a lot of in the last year, and is very common. And this is a 31-year-old male post-cardiac arrest after toxic ingestion of a narcotic. His total downtime is greater than 35 minutes. Comes into the emergency department. He is resuscitated. He has reactive pupils. Corneal reflexes are present bilaterally. CT head looks grim, and then he has a total loss of his gray white differentiation. And you are curious about his intracranial pressure. You're not feeling so bold as to stick a needle in his back or put an EEG in his head. So you think that you can maybe sort it out with transcranial Doppler, and indeed you can. So again, this all goes back to your knowledge of the basic NCA waveform. What does the normal MCA waveform look like? And it has the sharp systolic acceleration, this sort of tapering stepwise diastolic. And the take-home point that I gave you before is that your pulsatility index is your correlative of your intracranial pressure. And if your pulsatility index is greater than 1.4, and usually what that's reflective is that your diastolic velocity starts going down, and your peak systolic velocity stays roughly the same, again, right? Because mean flow velocity, peak systolic velocity happens with proximal processes and not distal processes, okay? So when you get your PI elevated, that's, you know, you have an ICP problem. So what you might see in a guy like this, as you do his first one, is you start seeing this blunting of your diastolic velocity. It turns into this kind of like rolling hips, okay? And when you see that, and when you lose your diastolic velocity, as we demonstrated in the general systems ICU a couple times this week, you know that your ICP has to be higher than your diastolic blood pressure because it is gone, and you're only getting peak systolic jets that are coming, and all the diastolic is gone. So often these people have ICPs in the 60s, 70s, and 80s, and from seeing those waveforms, you probably can't intervene because it's an oxygencephalopathy. You're most certainly going to progress to brain death. So I use it as sort of triggers to say, okay, this person is probably going to progress to brain death shortly. Okay, and often this case 1, does this person have ICP? Goes into case 3, does this patient now have cerebral circulatory arrest? Again, I'm telling you, be careful here, because if you didn't do the transcranial Doppler before, showing definitively that they had waveforms, and then you do it and they have no waveforms, you can't say anything because of the 15 to 20% unobtainable windows. But basically what starts happening is you start getting this oscillatory waveforms, you're actually in flow reversal, and then it peters out into nothing. Now, again, you're not going to say, oh, this person's brain dead, we're done. What often happens is, okay, let's now engage in a clinical brain death examination, or you've examined them and they have no pupils, GCS is 3, no other brainstem reflexes, but you can't apnea test it. So you want to do a nuclear medicine scan. It's happened to me many times where I've done a nuclear medicine scan and you see like a little tiny fleck of cerebellar flow, which is not compatible with life, but then you can't really use that as an ancillary test to say this person is brain dead. The power of transcranial Doppler ultrasound, and what I use it for the most, is that if you see a pattern of oscillatory flow or even just peak systolic flows like that, you will 100 out of 100 times not get any flow on your nuclear medicine scan. And I think that makes a big difference because you have to wait 3 days before you can repeat your nuclear medicine scan. And probably in those 3 days, you're not going to be able to apnea test that person. I think it makes a big difference moving forward, both for patient, family, physician dynamics, and organ donation, et cetera, et cetera, et cetera. Okay. And then just an ICP summary table that I don't need to go through. It's more if you guys want my talk and you want to see these slides for yourself when you're ever doing these scans, just as a sort of a treasure trove for yourself to see what ICP looks like as it changes in real time and progresses to cerebral circulatory arrest. Okay, the next example is not an uncommon one, and not the only use of detecting shunt, but in the cryptogenic stroke, so the stroke in a young person that does not have intracranial or extracranial dissection, does not have any vascular risk factors, you often start thinking about other things, and one of those other things that you think about is intracardiac shunt, in particular a PFO. And TCD is actually a little bit more sensitive than transesophageal echo at detecting intracardiac shunt. Okay, it's the same technique. You can use Valsalva maneuvers. You can instill blood with irrigated saline. It's the same exact technique. You're just insufflating intracranial vessels. Often really great if you have stereotactic ones on there, so you don't move your hand around and lose the insulation of the vessel. Okay. And so here's an example of a little microembolic hit where you get these high frequency stimuli that ride into your waveforms, okay? And that is like a low grade, no grade shunt, okay? Not uncommon to see that. But occasionally you'll see some real wild ones and you instill a little bit and basically all of those bubbles go across from right side to left side. And that's a high grade shunt, okay? And if you see that in a 21-year-old guy like that, that might push you to say, dear cardiology, please come and fix this PFO. Even though they never do, right, Sano? And then again, this is just how the grade shunt in this term of how many microembolic, how many bubble hits you get in your MCA territory waveform. Okay. Okay, the last case example is again, one that will be exclusive to neurocritical care, and thus neurocritical care is busting at the seams, and then you require a subarachnoid hemorrhage to come down to the dental system rescue. I don't think I've personally seen that, but I'm sure it has the ability to happen. But so, it's a 51-year-old female. Usually this happens around Christmas time, and you get a whole bunch of these subarachnoid hemorrhages. She has a big aneurysmal left subarachnoid hemorrhage. She's coiled on post-admission day 1. And now it's post-admission day 8, and all of a sudden, she was moving all fours, not bad, and all of a sudden, boom, she has this intermittent hemiplegia and gets a little bit knocked off in all these episodes. And so you're thinking, oh, this is probably vasospasm or delayed cerebral ischemia. And voila, you go incident the NCA territory waveform. Again, velocities are a proximal problem, right? Just as vasospasm is a proximal problem. And you get these huge waveforms, right? 300 centimeters per second, super high velocities. That's pretty good evidence that you probably have vasospasm in that territory, but you must be incredibly cautious when you say that, because mean flow velocity can be altered physiologically by a number of things, i.e. you get older, you get intracranial ratty vessels that are kind of like a garden hose at wintertime. Your mean flow velocities are going to go up, okay? And in particular with these subarachnoid hemorrhages, well, what do we do with these people? We pound them with fluid after they've been coiled, we drive their blood pressures up. Both of those things, you know, hyperemia and elevated MAPs are going to drive the mean flow velocities up. So the workaround to that is to say, is the thing that's happening in intracranial space the same thing that's happening in extracranial space, okay? And so that's called the Lingard ratio, which is fairly straightforward to do. You know, all you have to do is incinate the extracranial internal carotid artery, measure its velocity, and you do the same thing on ipsilateral MCA. And if there's space between those things, i.e. you have relatively normal velocity in your internal carotid artery and very high velocity NCA artery, you know it's not a MAP or a hyperemia problem that's driving all this. And again, it's a vasospasm problem. And that's just some right here in grading vasospasm, where you see that if your ratio, so if you have the MC to IC ratio, your Lingard ratio, if you have high velocity and high ratio, that gives you this critical vasospasm. You probably want to act up, right? By either making the patient more hyperemic, vasodilation, et cetera, et cetera. And again, just a summary of the interaction between hyperemia and severe vasospasm, and why it's important for the Lingard ratio and for the mean flow velocities. Okay, so the objectives of the talk are to learn the anatomy fundamental to TCD. I think we've done that. Get a basic sense of TCD technique. I think we've done that. To be able to identify pertinent anatomy in real time. Certainly have done that. And understand the basic principles of Doppler interrogation, TCD waveform analysis, and then how this applies to patients in the ICU. So thanks for Brian for letting me do this, and Vince and all the rest of the TCD guys for helping me out and allowing me to get the RPNI and allowing me to play around in the ICU and be a nerd. So if there's any questions, please. Sandy.
First of all,
Yeah.
I have a question about ICP measurements.
Yeah.
So it's really just telling you if it's high or not. You can't find out, like, it's not like vasospasm where you can find out mild, moderate, severe, or can you find ranges? Is that specific?
Yeah. So it kind of is a bit binary in that way, in that, you know, you can get like, I know the ICP must be at least this. When you lose that diastolic flow, it must be at least greater than the diastolic flow to give you that waveform pattern. But everything between normal ICP 10 to 15 and up to that, you really can't say. You can just say that I have elevated ICP, so it has to be greater than 15, less than 6, less than your diastolic, which is a pretty wide range, right? It doesn't give you much. Yeah, no one's really figured out how to do that just yet. Not wasted.
So just to carry on with that point, there's no way between 15 and 60 to distinguish, because you still have some diastolic flow.
Exactly.
Because over 60 is a bit of a sort of janitor diagnosis. Like, isn't it? You hope. Like, everybody knows he's screwed by the time he's 60. So is there anything we can do between 15 and 60?
Well, I think you know, if you saw it on ultrasound, and let's say you're not at 60, I agree. When you're at 60, like the writing's on the wall and the dream is over. But if you have a waveform that says I have high ICP, I must do one of two things. In fact, I must do two. One, I must act medically to decrease this ICP, and two, I must get neurosurgery on board to put in the appropriate monitor.
No, granted, but that would be in the 15 to 60
Right.
range. So I'm trying to work out how you would pick that up. I understand when you lose the diastolic flow, but that's too late.
Right.
So what's the sign you pick up early that you lose your control?
So if you look at the waveforms, so normal NCA waveform, let's just assume ICP is 15.
Okay.
As the pulsatility index rises, you know that it's becoming greater than 15, and it's lower than 60. So it's not so much the PI that I'm looking at, it's that is my waveform changing such that it's moving towards that 60. So it's a vector as opposed to an absolute number, if that makes sense.
It does. Does that mean when you would do a scan and then a second scan, you would see it worsening, or is it good enough that you look at it, say that PI is bad, you need it for food?
I think we're getting to the point where that is where it's become. I don't use TCD in isolation. I sort of hinted that we use ocular ultrasonography. So if I see an NCA waveform that looks sinister, and then I see an optic nerve sheath that looks big, I say, okay, mannitol 3%, whatever, neurosurgery. I need to know.
Can you go back to that slide, please, that showed the progression of the NCA? Yeah, that one.
Yeah.
So there's that meta-analysis showing the different techniques and the sensitivity for ICP. First of all, it showed that clinical Zen was awful, and then it showed that CP head was awful. And then it showed that TCD sensitivity was somewhere like around 70%, right? And not nerve sheath. Pathetically, there's difficulties with characteristics you study, but was around like 800 million data. So I think, you know, the problem is that, you know, if our gold standards are non-invasive gold standards before, we have challenges with using this technology because we don't have a monitor in place. So I think that will probably change over time because of this issue with frankly more gold standards with baseline. But I think in most cases probably combination techniques is warranted because the sensitivity just isn't high. But certainly, as Dustin pointed out, the specificity it is reasonably high. If you're running waveforms like this, with like a severely blunted diastolic velocity, that's pretty suspicious. And the next thing is really just a pretest, as you know. Like the pretest really does help guide your indication of therapy.
Yeah.
I just wanted to comment. I think for the majority of the patients that are going to be using this point of care, I don't actually really care whether my ICP is 30 or 60. All I want to know is that it's above the threshold that I need to use, right? If I really needed to know what my ICP was, I should get a CBP or a cognitive at that point. So all I need to know is like, am I seeing the pulsatility index is concerning to me? And does that correlate with my expected pathology, with optic nerve sheath diameter, with CT, whatever else I'm using? I don't think that any of these things should be used in isolation of the rest of your clinical judgment. But I think there is enough here to be able to say that an elevated pulsatility index acts as that threshold, whether you want to use 20 or 22 or whatever, and say, okay, my PI is greater than 1.4, as you said on that slide, or greater than 2, as it does in some other places. That's my threshold at which I will check. Yeah, I don't know where it is, if it's great, if it's 20, if it's 30, if it's 60, or if it's 70, but I know that it's high. And if I really needed to know that badly what it is, then I probably need to find some other way other than this particular measure to get an accurate B2B measurement of ICP.
Yeah, exactly.
That's how kind of I visualize that is.
I'm the same. I think of it as a vector as
Yeah.
opposed to an absolute. Yes.
Great. So can you differentiate between a intracardiac and intrapulmonary shunt on TCD, or when you're doing a TT or transesophageal, we differentiate based on the beats that we see problems constantly the other side? Is there a way to differentiate that?
That is a great question, Timothy. Don't truthfully know the answer. I don't think you really can.
No.
I don't really, you're so distal. So I don't know. I've never read of a technique where that's been done. Yeah.
But I do think that there's probably some truth to the fact that if you see really early interference, that the chances are it's like you're seeing within a second of basically administration. I think chances are it's a cardiac, because wouldn't make sense for that to be pulmonary fibrillation.
You have to be careful that you're like injecting out of the nine into not
100%, yes,
If
yeah.
you're into a peripheral, you don't know what your transit time
Yes.
is.
But it'd be very surprising because it is our pure circulation, right? You're interrogating, so
Yeah.
you know, to see if you have a delay of a few seconds, it's difficult. But if you see it immediately, I think chances are, unless you're injecting intraarterial, it's probably intracardiac.
Any questions online?
Dustin, I have one. Great job. Do you use transcranial Doppler at the bedside in the neuro ICU to assess whether or not your patient has intact cerebral autoregulation dynamically?
That is a good question, and you definitively can do that. I avoided that topic because it is a little bit hairy, but you can absolutely do that, yes.
And can I just ask, I know it's a tough one to cover, but what's your approach to assessing that at the bedside?
It's been a while since I've even studied it, so I think maybe I did it a few times. So I'd have to sort of go back and review my approach to actually assessing cerebral autoregulation. But you know, you want to use CO2, and I don't know if you've heard of this. There's a Robin Hood syndrome, a Steele or a subclavian Steele syndrome. So when you suspect some of those kinds of syndromes, you can make someone hypercapnic or hypocapnic to determine some of your autoregulatory properties. But I haven't formally done it in some time, so yeah, sorry.
No, thank you very much.
So maybe let's ask one last question here, Dustin. Just, you know, if someone was looking to learn this technique and, you know, has some experience with spectral Doppler, how many TCDs do you think them become familiar, you know, I guess confident in some of the basic skills of transcranial Doppler?
So, you know, if you look at the American Society of Neuro,
It's amazing. Yes, yes. He just said basically, I asked you about transcranial poker. Yeah, in case you're wondering, yeah.
So there's a lot of blocking involved in that.
Yeah.
the American Society of Neuroimaging, to challenge their examinations, suggests that you have to do 100 independent transcranial Dopplers with your own interpretation, overseen by someone that is trained in transcranial Doppler, to be able to write their exam to be confident. I found that probably 100 wasn't enough, to be honest with you, and you know, sort of on number of hundreds, so 200, 300 TCDs, before I really got comfortable with variation in normal MC pattern, how to insonate certain vessels, and certainly when you're going outside of the MC territory, you're in vascular territories, you know, it becomes a whole other ball of yarn. And when you're looking at other, you know, cerebral autoregulation, when you're looking at acute ischemic stroke, when you're looking at thrombolysis in the context of acute ischemic stroke, you need tons of them.
Yeah.
And then you're not even talking about these vessels too, right? The carotid vessels are part of that examination. So it's kind of long-winded, but you know, a few hundred, I would say, before you.
I think from the point of care standpoint, you know, I suppose I don't think it's the same threshold as you would do for that exam. I still think I still think it's going to be much more than, you know, say for lung ultrasound, maybe 10, 20, for example. I still think you probably need to have more exposure. And of course, that's only the NCA territory, right? It's not really the carotids or vascular or ophthalmic.
Yeah.
And just from looking from the bedside with COVID shunt, give us an interesting example of kind of what it takes to learn the technique. You know, there certainly are, it can be difficult to tell whether or not the patient actually, whether or not they have an issue with the non-insonation of the temporal bone, and people can sit there for a while saying, like, is there flow there? Like, is it not there? Is it there? And of course, you just have to have basically a thick temporal bone, which takes some experience to determine whether that's the problem or just where you are. So I think from our own personal experience, it probably takes like maybe 20, 30 at the very least to become comfortable with getting NCA velocity and capturing it appropriately and being able to make sure that you indeed have captured the proximity.
Dustin, when it comes to vasospasm, you know, we seem to focus a lot just on MCA and so on. How important is it to be able to insonate the other vessels when you're looking for vasospasm specifically, or is a sort of a proximal or an M2 MCA good enough?
So that's a good question, Leon. And you know, when someone does a formal TCD looking at vasospasm, all of those vessels are insulated. So AC territory, MC territory, PCA territory, and basilar are all insulated. Not every single one of them, because obviously every vessel is set up to have vasospasm. You have all that subarachnoid bleeding from, you know, myriad mechanisms. So sort of the problem is that there's a paucity of a standard within the literature for insulating the other vessels, and because you're going to run into some of the same problems where you want to normalize to an extracranial vessel. And so, you know, various different groups have used various different vessels, for example, for the basilar artery, as opposed to the MCA is always just MCA over extracranial internal carotid artery, your Lingard ratio. Does that make sense?
Yeah, no, it does, I guess. So I guess it's one of those applications for point of care that we should really be careful of when it comes to trying to make a call on vasospasm.
Yeah, I think with point of care ultrasound, you should be able to detect vasospasm in MCA territories and reliably say that is vasospasm based on a high mean flow velocity or high peak systolic velocity and a normal extracranial ICA velocity. But I would just be more cautious with the other intracranial vessels based on the paucity of literature on them.
Right. Thank you so much.
Okay. Thanks everybody for coming. Much appreciated.